Good evening, everyone. Thank you so much for joining us this evening. We're delighted to have Dr. Armin Schwarzbach with us again. Thank you, Armin, for taking the time. He's going to speak today about post-COVID viral reactivation, incidents and approaches. And I'll just introduce him very, very briefly, though I'm quite sure you all know him already. He is the founder and medical director at Armin Labs in Augsburg, Germany, and co-founder and former CEO of the Borreliosis Clinic in Augsburg. He is the medical doctor and specialist in laboratory medicine with 3 decades of experience in clinical medicine and laboratory testing. As well as being a clinician for many years, Dr. Schwarzbach has tested thousands and thousands, tens of thousands of patients for Lyme disease, co-infections, and most recently over the last 3 years for SARS-CoV-2 COVID-19. He specializes in laboratory medicine in many different areas: infectology, microbiology, immunology, hematology, and many more. He's going to speak to us today about this topic for about 40 minutes, and then we'll have time for questions. Please do put them in the chat or the Q&A at the bottom of the screen. And over to you, Dr. Schwarzbach. Thank you very much indeed.
Thank you, and hello to everybody. Thank you for giving me the opportunity during this World Championship semifinals, and I appreciate that you attended or you attend my presentation. Post-COVID is really getting more and more important in the consciousness of many doctors, also in Germany. And lots of clinics are coming now and doing therapies. We will not talk about therapies today, but we will talk about viral reactivations and incidences and approaches. The agenda for today is the first part, how SARS-CoV-2 acts as a viral reservoir. In the second part, I will talk about post-COVID and herpes virus reactivations, EBV, CMV, varicose zoster virus, herpes simplex, virus 1-2, HHV6. In the third part, it will be about post-COVID and enteroviral reactivations. In the fourth part, about post-COVID and association of other infections that live in the mucosal membranes, really interesting aspects. And in the end, we have developed together with the Academy of Nutritional Medicine, welcome Gillian too, for organizing that and moderating this evening, new Armin Labs post-COVID viral reactivation panels. About the S protein, there's a lot of publications and paperwork. What's really important that we can say nowadays that the S1 protein in post-COVID patients can be persistent up to 15 months post-infection. So that the body sprayed this everywhere in the body and trying to clean that. And Peter McCullough said, no wonder people have long COVID syndrome because of this. And also really important that this S1 segment infects the monocytes. Then they act as the viral reservoirs for that. You will see that also from other pathogens and viruses we discussed today, and also, let me say, bacteria like chlamydia. They are doing the same way, the same pathways, which is not so very well known among clinicians. So these monocytes are able to acquire a pro-inflammatory phenotype, and this is the viral protein reservoir and in the post-acute sequel of COVID-19. The herpes simplex virus group is really an interesting group in the viruses because you all know, all of us, or nearly all of us, we had these infections. And when I discuss that with therapists or clinicians and patients, they say, yes, I had this. The question is, could it be reactivated or not? This is a really new paper, a recent study from August 2022, and it said in this paper, it's also to me really important that in the long COVID group, the levels of cortisol, you all know it's a stress hormone, which has a role in the regulating inflammation. The blood sugar levels and the sleep cycles were about 50% lower than in healthy people. This really important message. Maybe we should check more cortisol levels in post-COVID, long COVID patients, and also the blood sugar levels and the sleep cycles, which is not so done very often clinically. So we should keep an eye on that. In this paper, which is a newer paper, the authors also found hints that in people with long COVID, Epstein-Barr virus, EBV, the mononucleose or kissing disease virus, varicella zoster virus, the chickenpox, and the shingle virus could be reactivated. And this is really interesting that normally we say everybody had this, but the question is, could it be reactivated? And yes, in long COVID, let me say so, this is absolutely possible. We know that from this story of HIV AIDS patients, where we named that opportunistic infections, the same group, EBV, CMV, varicella zoster. So this is not a new model. It's nothing new. So also if you get an HIV infection, you could get a reactivation of these herpes simplex viruses with a tragedy behind the story of this patient. The antibodies levels are elevated in patients with long COVID. So the long COVID patients particularly express Epstein-Barr virus. This is the paperwork also from August, and also to show you, they just checked the humoral immune responses, not the cellular immune response. It's also really important. So in this papers, something is missing always in the inclusion and exclusion criteria. So why not doing the ELISpot in this paperwork? Because they don't know how it works, cellular immune responses. Maybe they would find a higher correlation or maybe lower correlation if you check for the lytic and latent antigens in the test. We come later to that, but it's good that they check for the humoral immune responses to non-SARS-CoV-2 viral antigens, Epstein-Barr virus in the humoral immune response. To repeat this for you, it's the antibody immune response. Long COVID symptoms can be likely caused by this Epstein-Barr virus. Also in June 2021, there's an important paper. It's now nearly 18 months ago. In this paper, they said already, we found that 2/3 of long-term COVID subjects versus 10 of long-term control subjects were positive for EBV reactivations. And they said similar rates for months with these Epstein-Barr virus reactivations. Also that they said it's either simultaneously or soon after COVID infections. That means sentence what a lot of people, therapists think, or they say, yes, everybody has or had Epstein-Barr virus. The question is, could it be reactivated? This is a simple question. It's not the question that I had mononucleosis when I was 18 or 19, the kissing disease. This is not the question here. It's a question of this model, HIV model, where we know that opportunistic infections play a massive role in the inflammation process, in the immune suppression of these patients. So it's really complex in these models, and to check to maybe to think about what we learned in the 80s or 90s also about HIV infections. So various phenomena contribute to EBV reactivation in COVID. EBV can be reactivated by SARS-CoV-2, you have seen, you have heard. Also chronic EBV. Imagine there are also patients with ME who suffer for years with chronic Epstein-Barr virus infection. This can be exacerbated. So that means it's more active activity. So if you have had a fatigue for years before you got this COVID-19 infection, your fatigue will get stronger. And you say it's now long COVID, but what's the difference than before? It's a higher expression of your symptom because the virus is more active. I will show you later a laboratory test example. Epstein-Barr virus, whether dormant or chronic and active, can increase the susceptibility to COVID. We know also that if you have an underlying, maybe silent carrier, that you don't have symptoms from Epstein-Barr virus, but it's still active in your body, you control it with the immune system, then you could get easier the COVID-19 infection. But this is also pretty clear. The immune suppression plays always a big role in all of these infections. It's not just Epstein-Barr virus infection and SARS-CoV-2. In Germany, we also discuss now a decrease in CD8 plus cells, which are the primary cells responsible for the immunity infection. And it could be a correlation. This is still on a scientific level, not in the routine use level, to check the CD8 plus T cells and the natural killer cells. Natural killer cells, we're already doing in routine laboratories, a lot of these. This is an assay where we do the CD56 plus natural killer cells. And then we can see if there's a virus, chronic virus activity. Also, this is not a new thing. It came in the 80s, 90s from HIV infections. We knew that time that CD56 natural killer cells decrease during opportunistic Epstein-Barr virus infection in HIV patients. So it's nothing new. EBV DNA levels, really complicated to check for the DNA. DNA in the bloodstream, if you do a PCR, it's a PCR technique, you need 1 or 2 DNA molecules from Epstein-Barr virus, and it's really complicated. Maybe better if you have lymphatic system swollen, so lymph node swollen, do a biopsy and then check with the PCR in the biopsy the concentration of the Epstein-Barr virus DNA. Also, the drugs, interestingly, the drugs used in the treatment of COVID promote the EBV reactivation. So also a lot of these therapies, if you use corticosteroids, it's clear you suppress the immune system, you suppress the CD3 cells, you suppress the cellular immune system by that, the CD8 cells, the CD4 cells, the natural killer cells. You destroy the natural immunity of your cellular immune system. And this is a risk factor for herpes virus reactivation, but it's pretty clear. Everybody can imagine who is reading that. In July 2022, there was a study again on the impact of Epstein-Barr virus reactivation on the development of long COVID. That was a cohort of 280 adults with SARS-CoV-2 infection, and they found long COVID symptoms, fatigue especially, and neurocognitive dysfunction 4 months following after initial diagnosis. That they were associated with serological evidence of recent EBV reactivation. So serological means, again, antibody test, but not check for the cellular immune responses. And the question is which tests they are used for that study. Also really important if they use the early antigen or the EPNA, but always check the cellular immune responses in that. And this is how it should look like, not just checking the antibodies for Epstein-Barr virus, check the lytic antigen. This is very, very high active Epstein-Barr virus reactivation because the latent phase is there, 65 stimulation index, but also a massive reactivation of the lytic antigen up to 657. And you say, wow, but this is a quite normal result. We find a lot of these reactivations. This is not the antibody test. This is a cellular immune test of the interferon gamma release I come later to that. So it's really important to check also the lytic antigen. This is the gold standard test in transplantation medicine. So also the kidney transplanted or liver transplanted or heart transplant, they have massive or could have massively problems with these opportunistic infections, and therefore they are massively immune suppressed during their surgery or after that, so that they could get reactivations. And the transplant centers in the world, they don't do the antibodies because they are so suppressed with the corticosteroids, what they're using. They're doing this ELISpot test. And believe me, just 1 or 2 cells or spots on that are significant to say, wow, there's an active Epstein-Barr virus infection. I need to use a virostatics also. Here are a lot of references for Epstein-Barr virus reactivations and COVID, long COVID patients. So you could get this if you're interested. I think this is just a little part of the story. It's a lot of ongoing research in that, but it's more and more evidence about that. The cytomegalovirus, it belongs to the herpes virus group. Also, to me, very, very important virus, which we forgot in the world. A little because the Epstein-Barr virus, everybody talked about EBV, but not about the cytomegalovirus, CMV. And what we can see nowadays, a lot of CMV reactivations and virus-induced immune dysfunctions. Is exactly my way. I'm doing now for years. It's independent from SARS-CoV-2. I started with that before SARS-CoV-2, finding out that Epstein-Barr virus, cytomegalovirus, really huge problem in the Lyme disease patients group by the reactivation, a bad immune system with the patients suffering from Lyme disease. And what we also see here in this model, it's the same model with every infection. We can find a lot of reactivations and the virus-induced immune dysfunction. This is really important to say. It's infection, and it's also the immune dysfunction in this patient, and it's inflammation. We come later to that point. But also we need to know that these viruses always induce immune dysfunction, and this is really underestimated. This is not just my hypothesis. This is coming from a lot of experts now in the world. And this is, again, a driver. The immune dysfunction and cytomegalovirus are driver in the patients with severe COVID-19. So diagnosing cytomegalovirus in COVID-19 patients could be really, really important for this group to check this, not just the Epstein-Barr virus. And if you going back to the studies for the EBV, these groups are not checking the same time for CMV, for double infections, or maybe it was not EBV infection, it was CMV infection. This depends on the inclusion-exclusion criteria and the broadness of your view to say we have multiple infections. We find in every patient we diagnose multiple infections. It's not just the EBV, sorry to say that. And the stories and the studies, they are not correctly designed for that. Please, this is an important point. If you plan such a study, please also check for other viruses at the same time and not just for EBV. Everybody is fixed in a one-way street with a dead end EBV, EBV, EBV. Don't forget the CMV or other viruses or other pathogens. And this is really important for all of us. This is our daily work. We see a lot of these patients who already suffered from CMV infections. This was an example from May 2019, before the COVID diagnosis came, and after the COVID diagnosis in June 2020, you can find an explosion, 279. Such a high cellular immune response against cytomegalovirus. It's pretty clear that this patient has got a reactivation for that. And I don't have the antibodies in parallel. It's sometimes a question of the money for the patient. So antibodies are always complementary to the cellular immune. Bacillus zoster virus, maybe you heard about this. The reactivation, it's more and more following virus and the vaccinations. In Germany, we were not allowed to talk about something like that, but some months ago, we had such patients after vaccination. They got a varicella zoster reactivation and also some problems with that. But it's pretty clear by this vaccination, which could be also mean an immune suppression for you, can also immune dysfunction as a follow-up of this vaccination. Your immune system has a lot of work to do, and opportunistic infection like varicella zoster can be reactivated for sure, like all other. So this is a hot potato. So in Germany, it's now more and more discussed, but they name it a post-vax syndrome now. But we should think about that if it could be a reactivation also of viruses like varicella zoster virus. And we know that COVID-19 can potentially cause a reactivation of varicella zoster virus, and also this has an additive effect in neurological complications. And you know, all of these viruses, they are neuropathogens. They can inflame your brain or your nerve system. They can also inflame your heart. They also, we name it cardiotropic, and they can be also enterotropic. They can inflame your gut, so you get also some gut problems, diarrhea or colitis symptoms or intolerances. And also they can do arthritis as an example. It's not just that they can do neurological complications. Herpes simplex virus 1-2, better to say that. In this study, it was done of the herpes simplex virus 1. The reactivation could be seen in SARS-CoV-2 patients with severe pneumonia. HHV6 human herpes virus 6 in August 2022 also described reactivation of HHV6, 4.5%. That's not a huge percentage, but that needs to be respected. So if you don't find EBV active or CMV active or herpes simplex or varicella zoster active, please remember that HHV6, which can do also multiple sclerosis is a cofactor in this, can also be the reason for neurological symptoms of ME, fatigue, and so beneath EBV, or you have a double infection of both. But again, this study was not checking other viruses like herpes simplex virus 1 or varicella zoster. It's always, they check 1 or 2 viruses maximum. The enteroviral reactivations, also really important. I really favorize them to check it. We have also persistent enteroviral infection, long known to be found in ME, myalgic encephalomyelitis, especially the B1 subtype. We have a perfect test for that with the IgA test for Coxsackie virus B1. And there's a lot of evidence now, substantial evidence for persistent enterovirus infection in many cases of ME. So if a patient is suffering from ME and you have a long COVID patient, where's the difference, please? Patients with ME appear to have a higher prevalence of antibodies against Coxsackie B virus than matched controls. So also they found it in the stomach biopsies. Really interesting, because in my opinion, I thought it's more in the colon, in the colitis. It's more colitis virus, but also they found it in the, what we have learned, the sterility of stomach. So these viruses live in the stomach. They live in the whole gut, so they can live everywhere. Just to remember that. You know, it's a myocarditis virus, cardiotropic virus, although it belongs to the enteroviruses. It's a cardiotropic, it's a neuropathogen, it's neurovirulent virus. It can do myocarditis, pericarditis as a co-infection with COVID-19 patients. So if you have heart rhythm problems or something else after COVID-19, please check for Coxsackie virus. That makes absolutely sense. This is how we find it daily. This is worldwide. I think beneath EBV and maybe CMV, herpes simplex 1-2, varicella zoster is a Coxsackie virus infection #1. It mimics Lyme disease symptoms. It mimics where I came from, Lyme disease. So I find some patients, they don't have Lyme, they have Coxsackie virus infection, but also a lot of patients have both Lyme disease and Coxsackie virus. And this is so important to know for the therapists what to treat. Post-COVID could be also associated with other infections in the mucosal membrane, and now becoming chlamydia, pneumoniae, and mycoplasma. And in April 2021, chlamydia and mycoplasma were described. I think it was the first paper about that as a co-infection with SARS-CoV-2 and more severe features. And that was really a huge study with 721 subjects, and 443 were infected, 278 were negative, control group, and all were checked for Legionella, which we also doing a lot of pulmonary symptoms. Of this group of 443 individuals with SARS-CoV-2, 242 had antibody positive against mycoplasma and or chlamydia. Whereas the 278 were negative for SARS-CoV-2, only 97 showed mycoplasma and or chlamydia pneumonia antibodies. Interestingly, they checked for IgA, I try to mention that, IgA. So this is one of my favorite antibodies because it's mucosal produced antibody. It's really important, the IgM, to do that if you want to do that. But the IgA is the most important. You can find it on the right side in the middle. And they checked it really for IgA, which I appreciated that time because a lot of laboratories not doing that test. There's a very famous professor. I met him in 2005 at 𝐒LTS conference in Philadelphia, and his name is Professor Garth Nicholson. He's, I think, really a good infectious disease specialist in America. He's not so active the last years. He was getting older. I didn't see him the last years. And mycoplasma he named as the stealthiest of all stealth microbes, and they don't have cell walls. And he named it #1 infection in Lyme patients, mycoplasma around 70%. And in a cohort of ME patients, he also found 70% with mycoplasma infections, active mycoplasma infections. The problem of this mycoplasma is that they prefer low oxygen environments and they stimulate the reactive oxygen species, ROS, which can then cause the damage to the cell membrane. So you lose a lot of cell membranes. And on the right side, at the bottom, you can see mycoplasma on the surface of a fibroblast. Mycoplasma and chlamydia, the same story. They have a very huge affinity for mucous membranes, and it's everywhere with ciliary structures. The entire respiratory system, the small intestines, vagina, fallopian tubes, uterus, vesicles of the brain. It's in the brain, the eyes, photoreceptors, synovial tissues in the joints. And you can imagine what's now happening with that. So you could get Lyme-like symptoms or symptoms everywhere around your body, neurological symptoms, eye problems, also intestinal problems, gut problems, respiratory problems, biofilm. It's a biofilm producer also. This mycoplasma does a lot of biofilms also for therapists, very important. Chlamydia, these are the typical biofilm producer. They protect and hide behind that and do the quorum sensing. Most mycoplasmal symptoms come from infection and damage of the cilia. And interestingly, the mycoplasma is using the inflammation to make the epithelial and endothelial structures more porous, and then they can penetrate to deeper cilia, giving access to the mitochondria. And you know, then mitochondriopathy, fatigue, all of these patients have ME and have fatigue. So it's not surprisingly to people or therapists caring about that. Chlamydia pneumonia has also long been found it started in the early 90s, clinically relevant co-infection. It causes arthritis, also infection of the nervous system and the heart. And on the right side, on the left side, on the top, you can see Alzheimer's disease with the chlamydia pneumonia. It's well known, multiple sclerosis, schizophrenia, atherosclerosis. This is a typical atherosclerosis pathogen. It's a biofilm builder. It's also can do cancer, lung cancer, asthma, biliary cirrhosis, also arthritis virus, can do rheumatoid arthritis, Behçet's disease. This is really, really important for you to know that also chlamydia pneumonia, which plays also massive, very important role in long COVID, in my opinion, beneath mycoplasma, because of the reactivation. And always it's a reservoir in the monocytes and macrophages. Maybe I should really say that again. These pathogens, it's not just that they live in our sinuses or in the lung. They live also in the monocytes and the macrophages. And by that pathway, they can penetrate everywhere, into the spinal fluid, into the brain, can do the multiple sclerosis, infection, inflammation, destruction of healthy cells, mitochondriopathy, so make you fatigue. So this is really, really important to know, that the monocytes and macrophages always play a transport mechanism for these viruses, for the bacteria. In a lot of these, if you go into literature, these are the passive transport vehicles. Borrelia burgdorferi is one of the only one could move actively. These are really lazy pathogens, but they can come everywhere in your body and doing symptoms for sure. Chlamydia pneumonia also really important in oxidative stress, inflammation. For sure, every of these pathogens is doing inflammation. Cardiovascular diseases, we talked about it, strokes, heart attacks, IgA again, there are really popular studies about that, that you need to check this, the atherosclerosis patients for chlamydia pneumonia, also varicella zoster virus. It's an atheritis virus, we know that nowadays. And this is, chlamydia pneumonia came more into knowledge. It's now revival of that, interestingly, because we had that period in the 90s with the atherosclerosis, multiple sclerosis, all of that discussion. And it's really important that we have a lot of molecular studies. They highlighted the oxidative stress and the inflammation as the most likely pathogenic mechanisms are done by chlamydia pneumonia. And the atherosclerotic processes going on, promoting endothelial dysfunction, foam cell formation, platelet activation, thrombus formation. And here we are. Two eyes. Professor Jack Lambert mentioned that some weeks ago at German Borreliose Society. He said, okay, it's very well known nowadays that by Epstein-Barr virus, EBV, chlamydia, pneumonia, they can do foam cell formation, endothelial dysfunction, platelet activation, thrombus formation, coagulopathies. Coagulopathies, strokes, mini strokes, here we are. So biofilms, they clump, cold hands, cold fingers. So we are here exactly in the field where we don't have the oxygenation in our peripheral cells. We have the mitochondriopathies. We are exactly in that field. And for your therapist, you can imagine what that means. We can discuss maybe a little later. It's the activation of a thrombus formation is here shown. Also, SARS-CoV-2 is doing that. You can find it on the right side. SARS-CoV-2 contributes to increased inflammation, endothelial dysfunction, and in the end, thrombus formation. So strokes, little strokes, whatever, oxygen problems in the tissues. Chlamydia pneumonia is doing the same. Mycoplasma pneumonia is doing the same. Varicella zoster virus doing the same. They all do this inflammation and they endothelial dysfunction. And not in all patients for sure, but we need to find that out. Foam cell formation, again with chlamydia, vascular smooth muscle cells migration, proliferation in the intima, endothelial cells leading to thrombus formation. And then you got the strokes. It's all pretty clear in this. I want to talk in the end. We have, I think, another 10 minutes, but it's good. Then we have a lot of time for little questions and discussion. We have thought about with AONM, maybe we do some easy in this jungle of tests and how to find it out. If there's a viral reactivation, we said some weeks ago, why shouldn't we not do or develop some panels? And yeah, let me proudly present you some panels to that. The first panel is a post-COVID viral reactivation panel. Also, the prices are always important for some patients. It's easier panel. We just test for the lytic antigen, for EBV, CMV. We check for varicella zoster, IgG, IgM, IgA, and we check for Coxsackie virus subtype A7 and B1, the IgA antibodies, so important. This is the basic panel. Let me name it this way for I think a good price. And then to make me, not because of the money, because you get, I think, all of this information better because this selection is a selection and it's restricted. It's much better to do the advanced panel because what I talked about is all evidence-based medicine now. Do the EBV ELISpot with the lytic antigen and the cytomegalovirus T-cell test with the lytic antigen. So we spare the money in not doing the latent antigen. We need the lytic antigen if it's active or not. Varicella zoster virus, IgG, IgM, IgA antibodies, Coxsackie virus, IgA antibodies again, so important. Herpes simplex, IgM, IgA antibodies, HHV6 ELISpot, T-cell test, chlamydia pneumonia, I mentioned IgA antibodies, IgA. So we selected really these tests where you could spare also money for your patients. Maybe to mention in the end a little about tests, about the T-cell tests. It became more and more popular also in England with the quantiferon for SARS-CoV-2. You did a lot of these tests in with the company there. Also in Germany, we did this with the 𝐃𝐈𝐒. Now it's getting a little less of this effects, but it's always important to check the cellular immune responses to indicate active infection. The IgG antibodies, they are not so helpful. IgM could be helpful in reactivation sometimes, systemic reactivations, but where I favorize always it's the IgA antibodies and the ELISpot technique. It's an enzyme-linked immunosorbent spot. It's accredited for all of this, what I talked today about. So accredited technique, certified technique, so no discussion about the quality, external controls, there's nothing to discuss. So we do a lot of accreditation processes, validation, also with control with our authorities here. There's not a discussion about this technique to say it's a bad technique, it's a wonderful technique. It's a gold standard in transplantation medicine. Also in England, you have for sure some institutes doing the ELISpot for transplanted patients. So it's the gold standard for them. So it's really worth to do it. It quantifies the T cells and the cytokines, one cytokine, the interferon gamma release assay, and the expression is a stimulation index. And what I mentioned is a cytokine release assay. It's not a LTT, it's not a lymphocyte transformation test, it's a cytokine release assay. And if you don't trust this test, or some doctors or others, they said, no, it's useless. That's absolutely wrong. Don't believe these people. This is more the marketing part they are doing. My heart is in this test, not just from my story with Lyme disease for 20 years. The quantification of single cell interferon gamma release for assessing cellular immune responses using the enzyme-linked immunospot, ELISpot assay, is an invaluable technique in immunology. And if you don't trust that, please buy that book. I have it for sure in my library, 2015. And this is the word, this is the future of medicine or part of laboratory medicine, to check for interferon gamma release. And if in the book, there are a lot of studies also more and more coming about that, references, So why should it be a bad test if it's used in transplantation in medicine? So, and the next is, to me, very important, the immunoglobulin A antibodies, the mucous membranes, because all of these infections are in the mucous membranes, lungs, sinuses, stomach, and GI tract. IgA is an excellent immunoglobulin as it indicates current, ongoing, or very recent infection, as well as chronic persistent infection, reactivation, or reinfection. There are also different subspecies of chlamydia, pneumoniae, or viruses. You can get maybe a reactivation of Epstein-Barr virus from a different subtype. It's a family, but if you really have immunity, this is not 100% guaranteed. The major antibodies found on mucous membranes are secretory IgA. Secretory IgA in stool, some doctors are doing, which function primarily by binding microorganisms and thereby preventing their contact with the host tissues. Also in vaccinations with SARS-CoV-2, we find tremendously high titers of IgA antibodies. So not just the IgG antibodies. IgA has 2 binding arms, so it's good to bind 2 pathogens. It's very short half-life time. So it's a protein, 7 to 10 days half-life time. So in 3-4 weeks, if you do successful therapies, it should go down. It should be negative. So I just can pray, do the ELISpot. And ELISpot, I pray again, and I stay completely, there's no discussion, do the IgA antibodies. This is an example to show you that IgG antibodies, which are done by some labs, or the VCA antibodies or the EPNA, these are not the key. IgG, we do it together with that, because in some reactivations you can find a tighter movement in this, in varicella zoster with the IgA titer together, or the IgG reacts earlier than IgA, or it's earlier boosted. But the IgG is produced in a delayed response to an infection and can be retained in the body for a long time. So we say it's a past infection. In this, the detection usually indicates a prior infection or vaccination. So the IgG in this practical case, it's not so helpful for chlamydia pneumoniae. It's the IgA which was the key to diagnose this patient, also for mycoplasma. IgA. We do a lot of these for chlamydia pneumonia, Yersinia, Campylobacter, also the gut pathogens, the gut bacteria, mycoplasma, herpes simplex virus 1, 2, varicella zoster, Coxsackie echovirus. Always I favorize the IgA if I have a test for that. For toxoplasma, we don't have it. We are now checking that on the market. I think we will get an IgA for toxoplasma to find out the active reactivations or persistencies. So the story is going on. For Epstein-Barr virus, you need to do 9 markers, including the viral capsid antigen and the early antigen. This is the key, EA early antigen. If laboratory is not doing early antigen, forget about this. You will not find that. Epstein-Barr virus, the EPNA, EBNA, this develops 6 to 8 weeks after the first contact with the virus, is a helpful thing, but the early antigen is the key. As you can see here, that's clearly, in my opinion, a reactivation or chronic persistent infection, early antigen, and do the big 9, please. What was going on the last months? Also, we developed electronic checklist, which helps to decide which co-infections to test for in post-COVID, because there are a lot of these infections, also parvovirus B19, we didn't talk about that, Yersinia, Campylobacter, reactivations, chlamydia, mycoplasma we talked about. And what you can see here, that costs no money, nothing. You can download the 𝐷𝐸𝑁 website. It's free of any cost. Patients fill it out. It's digitalized. So for Apple systems, we have special applications now for the PDF file openers. So you can find a ranking by that. So, and the more symptoms you have on this list for an possible infection, the higher is the test probability that you find really positive test results in IgA or ELISpots we are doing then. So it's always helpful for you. If you favorize the panels, I would say yes, but this could be also an idea for you also to monitor patients for doing before therapies, this list, and after therapies, and to correlate with the laboratory test findings. And the Academy distributor in England also, they offers you a discount 15% for anyone paying before 23rd of December. So hurrying up, could be a Christmas present, to check this if you were suffering from post-COVID, long COVID infections, really. And also during the new year, we are working really hard in the laboratory. If you want to download this checklist, it's free cost on the www.aonm.org website. We did a lot of these presentations now, 2019. Interestingly, before COVID, we started already with that. Gillian Crowther did it in Dublin. Interestingly, she said which test for which virus without knowing that the big virus COVID-19 would come to us, and means a better opinion in the medical communities. And I did a lot of these presentations with Academy in England together. Lyme disease and viruses, always their role in degenerative and autoimmune conditions. We did also presentations, tick-borne diseases in viruses and cancer and unexplained symptoms. And you know me, maybe some of you, and I did also some presentations already on SARS-CoV-2 and viral co-infection. Yes, and that's it, 45 minutes. Thank you very much for your attention, and I hope for a little discussion now.
Thank you very much, Armin. Fascinating, brilliant presentation. We've got several questions already. The first one concerns the effect of COVID vaccines in viral reactivation and disabling of the monocytes. And because that's a slightly different topic in the sense that there's massive information out there, but I think that would require a really proper workup. I think we'll sort of leave that, if that's okay with you, for another time. Obviously,
yes, interesting.
We would need chapter and verse on that. We would need the science. We would need the figures. I mean, other people
Exactly.
have gathered that, but I know that hasn't been your prime concern. So
no, but you
ahead.
can see, Gillian, this is a point we should work on that. Maybe we will next presentation about that.
Yeah.
It's also an interesting chapter about the monocyte macrophages, how they're transported, how we can diagnose maybe some pathways, how we can diagnose the macrophages and monocytes. We have some CD markers, really interesting point. Thank you for this input. This is clear to me because I knew about chlamydia pneumonia and mycoplasma, how lazy they are, and the virus is doing the same. They're using monocytes and macrophages for sure.
Yeah. And then another question is, if you have a high latent value on an ELISpot, but not a lytic elevation, can you tell us a little bit about the significance of that? And the question also goes on to say, how would you treat it?
Yeah, always treat the symptoms, not the latent phase of a virus. I think we all have a lot of viruses in us with a lot of latent sleeping phases. When you have herpes on the lips, as an example, it's not always coming out, but it's maybe a little active in the deeper tissue. On the other side, if you have a high latent, it can switch to lytic phase. There's always the option, if you have an immune dysfunction or if you're using corticosteroids, you do immune suppression, you have cortisol problems, you have stressing factors, or you're getting SARS-CoV-2, it can switch immediately. But you have a result that you need to keep an eye on this latent phase. Like you had this shingles before. You had shingles, you have now herpes zoster reactivation. Yes, and if you have had a vaccination maybe for varicella zoster, it could happen with a shingle or the first phase of this infection, again, a fresh infection, if you're not immune competent enough. So check the antibodies maybe, or the cellular immune system. But on this side, it's absolutely true that it can switch from latent phase to lytic phase again.
Yeah. I remember you also telling me about the syncytia, which have become a big topic following discovery that COVID-19 is very able to move in a sort of syncytial way, in that it forms multinucleate cells, and that's how it moves from one cell to another and infects them. And it's of course possible and clear actually that many of the herpes viruses do that as well in latent form. I remember you finding that and telling me that. So it could be kind of moving within the body. I think Epstein-Barr virus is known to do that, isn't it?
Yes,
to cause other diseases eventually if you have it for a very, very long time in latent form.
It's tricky. It's tricky.
Quite difficult. Yeah.
It's tricky to like a chain. You produce a chain, the chlamydia chain or mycoplasma chain. You get babies, and you get into different production phases again. And I just can say what's the best technique we can find that out. We cannot find the virus directly. It's so complicated. You need biopsies, and also to check it with a biopsy, it's not so easy to find it in exactly that part of your biopsy. So maybe it's not in this part of your biopsy. We tried a lot of the PCR, and if the PCR is positive, that doesn't mean that it's still active. You need to culture it, and to culture virus, it's really complicated.
Yeah, understand. Thank you. Another question here is a little bit longer. Any thoughts on therapeutics to either accelerate the removal of spike proteins or to mitigate the broad viral reactivations discussed? Does Armin Labs correlate interventions used to follow up test results?
Oh, this is a good question. We are not a scientific laboratory. On the other side, we have for sure patients. We do following up of spike proteins with tests, but simply I don't have an overview or data for that. I could imagine that this could be a problem, but to say it clearly which products or which therapies are the best in this.
Well, we will be following up with together with many others who are also giving talks on that regularly. We will also be following up with some talks on it. We did make that promise to ourselves last year, and we will be having some specialists early next year. A follow-up question from the same participant: when might Armin Labs testing be available again in the US?
We are working on it. It's the door is open. It's really getting broader open. It's a formalistic question of the paperwork, nothing else. So we are completing it, and let me say in a very few weeks we can start.
Okay.
Revival back, yes.
Thank you. Yes, that question has actually come up a couple of times. One attendee noticed the very high level of IgA on the chlamydia pneumoniae and the mycoplasma slides that you showed. It was over 7,000 IgA for chlamydia and over 10,000 for mycoplasma. Or I think that's the comma is really a dot, isn't it?
That's a mistake.
But the reference range is a 1.1.
Exactly.
Above that. So she's wondering about the significance of such a high load.
This is really a good question. In such high levels, I would always check also for maybe some polyclonal thing. If you have the same patient with a lot of high IgA and no IgG, this is strange. You need to check the immune globulin A in total. You need to do protein electrophoresis and maybe immune fixation if it's not a monoclonal thing, because we know that these pathogens can also do monoclonal gammopathies if you're not careful, and they cannot switch to IgG. So there's just one clone in our stem cells producing IgA, signaling that to the protein, and such high protein concentrations are also not good for your kidney. You could get an IgA nephritis. So this was a 7-fold higher titer. It's absolutely correct. This is not maybe to show an extreme version of a report. This is not quite normal. Normally it's two-fold higher or 3-fold higher maximum. Yeah, it could be a polyclonal thing. A high IgA titer is also not healthy. Without IgG, something is going wrong. You need to switch into IgG after you overcome the infection. You need to check IgA in total. Be careful for your kidney. In these patients, IgA nephritis is possible, and also monoclonal gammopathies. These were my last
but I mean, a high IgA load is also of great significance, isn't it? And can be really.
Yeah, the antigens are 99.9% specific.
Yeah,
sure.
Okay, thank you. And so would you recommend with a patient like that to go ahead and treat as well and not to wait too long, or to do those further additional tests?
No, they all have multiple infections. It's not just chlamydia. Chlamydia is a part of the story. They all have viruses, all. And you need to know if chlamydia you would treat with antibiotics, rifampin, or and combination with doxycycline. There's famous Stratton protocol from USA. I heard him in a presentation, Professor Stratton in Seattle 15 years ago. So it's very famous in this chlamydia, and he's using doxycycline combination, the same like a Lyme treatment. But if you have a virus additionally, that's always the question. Do we need a virostatics? Do we need to treat the virus? What should we do with this situation? Or should we use the antibiotics and do a provocation of the virus activity and destroy your gut? The gut is 80% of natural immunity. We know that.
Yeah. I'll read here. This is a specific patient case, but obviously it could be relevant to many here. After having COVID Omicron, I developed POTS, but also microcytic anemia with very low ferritin and hemoglobin. Do you believe viral reactivation could be behind this specific long COVID symptom, which in that case was anemia?
Yes. 𝐃𝐄𝐒, interestingly, I thought about anemia, maybe Babesia, if there was also reactivation of a tick-borne illness. Rickettsia can do that. Also, cytomegalovirus, really important. The anemia is not so clear to me why this should develop. Maybe this multiple infection with Babesia, I don't know. But fill out the checklist, then you know.
Okay. Another therapist here writes, I have a client with Behçet's syndrome. Is it just chlamydia pneumoniae responsible for this or other viruses?
Also, mycoplasma is doing that. We need to say chlamydia mycoplasma. They belong together in communities also. But I would also in Behçet check for viruses. Yes, Epstein-Barr virus primarily. Yeah.
Okay.
Cytomegalovirus in the gut. CMV is such a huge colitis virus in the Crohn's and the colitis group. Internationally, we diagnose so many patients with colitis and CMV.
Okay. And the same therapist asks, do you know if it's chlamydia pneumoniae or herpes simplex that induces multiple recurrent mouth ulcers?
Inside the mouth, it's more the 𝐃𝐒 virus, the herp angina. We don't have a picture here in our presentation, but if you Google herp angina, you will find it, and it hurts in the mouth. Outside on the lips, it's more the herpes simplex subtype 1 or maybe also 2. So outside, it's more herpes simplex, but it could be also very few cases inside. But this is clearly, in most cases, herp angina, 𝐃𝐒.
Thank you. And again, because you've interested people hugely in the IgG, IgM, IgA aspect, another question. I had a negative IgG, IgM chlamydia pneumoniae test in 2016, and now my numbers are very high, including IgA. Does this suggest I caught this infection post-2016?
Yeah, or you didn't do the IgA that time and you missed simply information. Okay. Maybe the IgA was also high. To say something about high titers, if you have an ELISA and the result is 2.0, a significant change would be 4.0 or more. So if you have a result of 3, you need 6 point. This is significant titer development. Not to say, oh, I have now titer 1.5 and now I have a titer 1.7. There's a significant change of your IgG titer. Sorry.
Yeah. Thank you. One further question about availability of the tests. Are they available in Canada?
Yes, Canada, we have a strong community of therapists, more at the West Coast. The East Coast is restricted. Naturopaths, as an example, are not allowed doing some ELISpots. They are just allowed doing antibodies in Ontario. But British Columbia, yeah, this federalistic system. If you live in Vancouver or you going there or Calgary, it's perfect.
Thank you. Just time for maybe a couple more questions. What virus is likely to underlie Crohn's with anemia, please?
Yeah, the Crohn's, we have also a panel developed. It's Yersinia, IgG, Campylobacter. This has to do with your meals with pork and eggs and mayonnaise as an example. Campylobacter IgG, the cytomegalovirus, you do the ELISpot for that, not the IgM, not helpful. You do the Coxsackie virus IgG, and in Canada, very famous, also in England, the Coxsackie infections internationally. The 𝐄 virus also sometimes, we have double infection with 𝐄 virus IgG. So I would say Yersinia, Campylobacter test, and CMV to be checked. Also EBV, Epstein-Barr virus, if you have some fatigue and some swollen lymph nodes sometimes in your neck. So you also should check this. EBV can be also enterotropic virus. CMV, EBV, what I mentioned, Coxsackie and 𝐄 virus. I think you have 6 different, and this you can treat this successfully if you have that active.
Thank you. Thank you. Several questions have come in regarding therapy, which we will, as mentioned, address next year. So we'll, when I say next year, that's just within a few weeks. So we will take note of all of these questions and address them. One here, Armin, perhaps to finish with, is whether you've seen cross reactions between viruses that you've discussed today and mycotoxins.
That's an interesting question.
Yeah.
I would say also yes. This is appealing the onion model. So we have in these patients also, I mentioned cortisol, hormonal problems, glucose problems. We can find autoimmune irritations. So the aflatoxins we are offering, I think over next week, we start with a Toxiplex test from Professor Gilbert, and which is done in a famous clinic in Mexico already, in Sanofi clinic with Mark Heyman. So we know that these mycotoxins play a role in chronic infections together, or triggering factors, or we cannot say now, or but we belong together. There is surely a group where we have a connection of both. So we need to check this, and we inhale that. We have also immune. We find a lot of Aspergillus infections. We forgot to talk about this, yeast and mold, and we find also the Candida infections. So the environment plays for sure a very important role nowadays.
Especially in England, small islands surrounded by water and old buildings and lots of damp. Maybe there'll be an opportunity to do more correlation of mycotoxins and infections as you introduce Toxiplex. That's a possibility, isn't it?
Yes, it just
could be very interesting to kind of correlate that when
Gillian,
people test both.
Also London is a toxic city for that. If you go to the old hotels, and I was last week at the House of Lords, House of Parliament in London, and I was thinking about these carpets in the hotels, the old buildings. So that some need renovation here. Okay, we have in Germany also some problems with that, but not such big ones as it is in London, as an example.
Well, also. Germany is much more enclosed, isn't it? It's not surrounded by water like the UK. Yeah. Well, thank you so much. We were delighted to have you, and that was fascinating information, Dr. Schwarzbach. Thank you, everybody, also for spending this precious evening before Christmas with us. And we will definitely have more webinars going forward. Look forward to talking to you all again and having you back again very soon as well, Dr. Schwarzbach. But I apologize for the fact that somebody's mentioned that the checklist isn't yet activated on the website. All of that will be fixed over the next couple of days, maybe hours, so please don't worry. This is all quite new, but we're very excited about it, and look forward to correlating these results ever more with you. So thank you, Armin.
Thank you. Merry Christmas and Happy New Year, I want to say to everybody.
Thank you very much. Same to you.
Thank you.
Bye-bye.
Thank you. Bye-bye.